First man up is Iain Anderson, an old friend of mine, consultant surgeon for one of the happy hospitals in Manchester, where everyone gets on well and Devo Mank has not upset anybody. And Iain is going to talk on the subject of NELA, 2 years of patient data, and what does it tell us? Iain.
Thank you very much, Mr. Chairman. Ladies and gentlemen, good afternoon. Thank you all for submitting what you can now see as 40,000 of those awful NELA forms to give, or to begin to give, some of the answers around this important part of our practice. 2 years of patient data we've now gathered. Those of you who fill forms in, I assume, will know what NELA is. In case you don't, it's a compulsory national audit that every trust has to take part in. The aim is straightforward. The method is by publishing comparative data from all providers at a hospital level, as you'll see. So not an individual surgeon level, at a hospital level. And the quality of care is assessed against published standards that you can access and which are referenced in the annual NELA reports, which are available on the NELA website. Why should we take all the trouble to audit this? Well, it's a common and high-risk operation. 11% mortality at 30 days, that continues to rise, particularly in the elderly. A high complication rate, it's the biggest single user of ICU, about £80 million a year, so of interest to health providers. There have been numerous criticisms, as you'll know, of the way the service, the EGS service is provided, the way it's resourced, and sometimes managerial and medical commitment to it. NELA records about 89 things, some of which we'll go through and talk about in the next 15 minutes. Most importantly is the trend in mortality. The mortality is round about 11% for all comers. And if you think back to the Saunders pilot paper from a 2010 cohort in 35 hospitals, the mortality then was 15%. The mortality in the first NELA report was almost 12%. So there's probably a downward trend there, probably a reflection of the huge amount of effort that's been put into emergency surgery. If you've been to some of the other sections in this symposium, you'll see there are numerous individual hospital audits looking at aspects of practice, many of which have changed outcome in their own hospital. We'll come back to that. Mortality rises by age, and you can see here that somebody in their 60s has almost a 10% mortality. And I highlight that because 10% is the level at which the standards mandate that there should be consultant involvement in every step of care and there should be critical care admission for all patients. Whether we achieve that, you'll see in a moment. You'll see that mortality rises to over 20% in the octogenarians, and they're quite a sizable chunk. They're a fifth of our population here. And the following speakers in this symposium will highlight some of the reasons why we need to start thinking about that group, what's appropriate and what isn't. This slide shows the mortality by urgency of surgery. The NELA audit lets the surgeon define, should the surgery have been done within 2 hours, people in septic shock, for example, but the largest group is this 2 to 6 hour group here, the standard urgent laparotomy with organ dysfunction. Most of us would think that most patients should be operated in that time frame. So you can see that mortality falls the less urgent we think the case is, but when you look at the older patient at the over 80s, there's the impact of being over 80 and having more urgent surgery. And you see that for the most urgent surgery, the mortality in the over 80s is up at 37%. That's an average. So there's some who are very much higher than that. And one of the things we need to think about are the conversations as to what the outcomes are realistically, and maybe who should and who shouldn't be undergoing that sort of operation. Death correlates with ASA, and again, just to highlight, the 10% level is at ASA 3. So if you have an ASA 3 patient or a patient over 60, they've got a 10% mortality and should always have consultant input and critical care admission. Deaths account for about 10%. So what about the 90% survivors? Well, in the nature of health economics, they're more likely to interest the hospital manager. And here you see the length of stay. And what I draw your attention to here is this huge long tail. The median stay is about 11 days, but a quarter of patients stay more than 3 weeks. So that's a huge proportion of your patients occupying a lot of your surgical resource and beds. The octogenarians stay more than double their length of time, and you can see that length of stay increases with ASA and operative urgency, perhaps not surprisingly. Care of the elderly input has transformed urgent orthopaedic care, but it's making very slow progress into the general surgical wards. You can see that only a couple of hospitals, this bar chart here, I'll show you several of these. This shows each of the 190 hospitals' performance plotted out. And you can see there's only a couple of hospitals who go over the 80% line for adequate provision of care of the elderly services. Our care of the elderly services reduced length of stay and readmission rates. But overall, only about 1 80-year-old in 7 gets to see a care of the elderly doctor in the country. So, what about the components of care? Here's what your ideal emergency laparotomy pathway might look like. And again, NELA evaluates many of these individual aspects. So let's have a walk through some of those. One of the most controversial is the Academy of Joint Medical College's diktat that everybody should be seen within 12 hours of presentation at hospital by a consultant. Something that's hard to argue against when it's your parents, something that we're all not so keen on when it's us on call. And you see that less than half of emergency laparotomy patients are seen within 12 hours. It's more likely for patients who come in at night, and that reflects our usual pattern of a post-take ward round in the morning, but maybe not a second one in the evening. And we are better at seeing more urgent cases where the odds of being seen within 12 hours goes up. That 50% average varies very substantially by hospital. There you can see the 50% average. There are some hospitals who are very far below that, and there are some hospitals who have organised services so 12-hourly review is routine. What we don't see is any progress with time. We seem to be stuck where we are for this particular aspect of care. There's been no real change in that, unlike many of the parameters that I'll show you, which have tended to improve over the 2 years of the audit. CT scanning is now pretty much routine for patients having an emergency laparotomy, and this shows the orange is performance of CT, blue is performance of CT, orange is reporting of the CT. You can see the average figures there, but you can see that about a quarter of hospitals have very low rates of CT scanning and considerably far below their peers. And again, one of the advantages of having the NELA document is to be able to go to your head of radiology or your medical director and say, look, everybody else gets this, why can't we have this too? So the aim of the NELA document is not to beat you with, it's to use to acquire the resources in a competitive and strained NHS that will help you deliver the service you want. And you can see that in patients having immediate surgery, 2/3 of patients get scanned, but just compare that for a moment with trauma, where every major trauma patient gets a CT reported within an hour. The outcome of these patients is substantially worse and more risky than the trauma patient, and it's been said before that maybe one of the things we need is a national pathway, much like the national trauma pathway. The first annual NELA report that came out last summer talked a lot about predicted mortality, and that was always a bit unsatisfactory, but what we have now are corroborated Office of National Statistics, ONS, survival outcome figures, and you see that the risk groups that we define, lower risk, less than 5% chance of dying, high risk 5 to 10, and highest over 10, the predicted P-possum mortality actually matches very closely with what happens at the end of the day. You see that length of stay rises with predicted risk, and you can see that in where we don't predict risk, the outcome is not low risk, it's pretty much the same as the high risk group. How often do we predict risk? Well, this slide shows you that. We predict risk in about 55% of patients. Why should we do that? Well, two reasons. One, to inform patients of what the outcomes are likely to be, but perhaps more importantly, seeing they'd probably go ahead with operation anyway, is to mobilise adequate resources, senior staff, critical care, etc., etc. And what you see is that in units that don't predict outcome formally, the patients do worse in terms of outcome than expected, in terms of consultant involvement and critical care admission. One of the many abstracts on laparotomy at this meeting again showed that the use of critical care correlates with survival. You can see that with those data that the change in time of predicting risk is increasing as people realise its value in being able to engage your critical care colleagues in particular. What about access to theatre then? Well, here's our self-imposed classifications of how urgent surgery is, and you can see how often we get into the operating room in the desired time frame. The spread of hospital data that you see here is maybe not as wide as with some, but there are still some hospitals who struggle to get a decent number of patients into theatre. Again, if you're down there, you can use these data to get better access. And it's staying relatively constant with time. The argument sometimes raised, well, nothing's that urgent, is it? It can wait till morning. And there are data now coming out that tend to suggest that may not be quite as easy as that. Here's the Danish data on survival after perforated peptic ulcer. It shows that as the time from admission to operation increases, the proportion dying increases also, and that steps in hours make a measurable difference in these population databases in terms of outcome. And we sit down about there, so room for improvement. What about the NELA data? What do they tell us about that? Well, one of the subgroups we've looked at is the population of patients with peritonitis needing urgent surgery. And you see the average time to antibiotics, time from decision to operate to getting to theatre, time from admission to theatre, but just look at the interquartile ranges. A quarter of patients took more than 7 hours to get antibiotics for peritonitis, a quarter took more than 4 hours from decision to theatre, and a quarter took more than 13 hours from admission to get to theatre, which doesn't sit very well with the preceding slide. It may be that it's the initial assessment, the making the decision, that's more of an issue than actually getting into theatre. And that comes down to pathways of care and organisation of services, perhaps more so than theatre access. This shows the progress with time of those two things. You can see that time from admission to first dose of antibiotics, year 1 here, year 2 here, it's got slightly better, that's the blue line. Time from decision to operate to arrival in theatre also got slightly better, but getting somebody from deciding into theatre in less than 2 hours, there's limited room for logistic manoeuvre there simply because of how hospitals work, I think. What about consultant involvement? Well, this was looked at in 2 steps. The guidelines state each high-risk case should have active input of consultant surgeon, consultant anaesthetist. You can see that about 60% saw both consultants pre-op, but a big variation between hospital. Here's the individual hospital chart. There's the 50% line. You see that about 1/3 of hospitals are down comfortably below 50%. Presence in theatre is perhaps the most talked about one. Both consultants present in 2/3 of patients, but a big hospital level variation. A quarter of hospitals can do it almost all the time, more than 80%. But there's a decent chunk who are way down here who are considerably behind the curve in having consultants in theatre. Look at the change in trend after the first year of data. The pattern has been increased consultants. Surgeons in brown, we behave better than the anaesthetic staff who are in blue and lag behind at about 10%. And what about the highest risk patients? Are we there more often for the highest risk? Well, generally we are, but at over a quarter of all hospitals, you have a less than 50% chance of seeing both consultants in theatre, even though your risk of death is more than 10%. What about by time of day? Surgeons in blue, anaesthetists in brown, risk of dying in grey. You can see this is the morning, this is the afternoon, about the same. Surgeons, it's about 88% presence, anaesthetists slightly behind. Evening, it falls off, although the risk of dying is increased. Nighttime, it's fallen off further, although the risk of dying has almost doubled from the daytime. So food for thought there in how we organise care. What about post-op critical care? We've already said that that's known to make a difference in several studies to outcome. All patients, about 60% of patients get there. It's not changing with time. The highest risk patients, 83, 84% get there, but again, a big change by hospital, a big range of variation by hospital. So about a quarter of hospitals have room for manoeuvre to get up to where everybody else is. So you might say, okay, you've shown us all these things about CT scan, consultants, ICU. Does it make a difference? Well, this is what's called a radar plot that shows all these process factors around the edge. I know you can't read the individual text, but you can see that the hospitals with the worst mortality generally perform worse than the hospitals with the better mortality. Most of those changes where the green line is away from the red line is significant statistically in terms of outcome, usually at p less than 0.001. So you can see that systems that work well make a difference to outcome for patients. And we shouldn't really be surprised about that. The ELP-QUIC study published in the BJS in 2014 showed that if you have a care bundle for emergency laparotomy, you can make a very significant difference to your outcome. You get patients in theatre quicker, you get more of them in ICU. It was published by Huddart, if you're interested, in 2014 in BJS, and they showed that that made a difference at all 4 sites that took part, and the overall survival in the over 75s was significantly better by using a care bundle. The other piece of data that points to that, this comes from the Saunders paper, which was the pilot study for the NELA data, if you like, and that looked at 35 Keene hospitals. This is the funnel survival plot and all the hospitals named. And you can see that Hospital BF, which is a large number of patients and excellent outcomes, when you look down how good they are at consultant input, CT scanning, ICU use, they're extremely NELA positive. They do all those things, and that may be one of the factors that impacts in their excellent outcomes. So this is how the first NELA report and the second one will show your hospital to the world. This is from the first one, so there's nothing confidential here. That's a list of hospitals by name. These are all the processes, and some are green, which means good, some are red, which means bad. And if you want to improve your own care, one way to do is to find your hospital and look along it and see what you're red at, and that's a good place to start because you're falling behind your peers in terms of how you deliver services. This is how we judge it. The green things means you meet the standard for more than 80%, so you don't have to be spot on with every case. That's not possible usually in a hospital system. Red means you're meeting the standard less than 50%. How are we getting on overall? Well, we should have 1,900 green boxes. We've got about 500 at the moment. So there's some way to go in terms of resource provision and structure of services as well as individual performance in order to try and make things better. And that's really the crunch of NELA and the report that will come to you in July, is that it's all very well to have a national report with the big figures, but it's about local quality improvement. And one thing I guess I've learned is that no one's going to come from London to tell us what to do in Salford. We need to look at it and see what we're not so good at. We sit bang in the middle of the survival stats, I can tell you that for free. We're not an excellent outlier, although there are some, and we've got lots of red boxes too, and our focus is on turning those red boxes amber and then green and see if that makes a difference. And it's very encouraging to see the number of presentations here at this conference of other colleagues from other teams that have gone and done that, some of whom have altered outcome. And you can hear the winning NELA paper tomorrow morning, I think it's at 9:20, which outlines the progress made in one hospital. It's not just us that do it. The North Americans, the ACS have NSQIP, and they've showed that taking part in this sort of process of local quality improvement and audit improves outcomes, reduces complications, and saves money. What about individual operations, you might say? Well, there's a huge amount of data there. Small bowel obstruction, best part of 20,000 cases now. Adhesiolitis, right hemicolectomy, Hartmann's, there's a list there with the mortality. You can see The next step is for us to look at that with the specialty associations. We have about 5 projects that are ongoing, and by this time next year, you'll already begin to get the results, hopefully before then, of individual disease messages of maybe how we are and how we should be managing some of these conditions. We talked about laparoscopy in the service before, in the session before this. About 6% of patients, about 13% of patients have open surgery, 6% are completed laparoscopically, 6% start laparoscopically and are converted to open. So that's a 50% conversion rate. So there's a conversation to be had there about exactly how that should be developed. One disease-specific plot I can show you, and please note these are draft and not risk-adjusted data, so don't take pictures of these, please, and don't share them because they're draft. You can see the spread by hospital of the outcome for small bowel resection. Eyeballing the data, it's between 15 and 30 cases per hospital, so it's modest numbers, maybe not enough to compare hospital to hospital, but you can see there's a load of hospitals with 0 mortality, and you can see there's a number who are way up here, well over the 15% mortality. So it'll be interesting to look into that, particularly if you're one of the hospitals in the bottom quintile. So in looking at the details of the NELA data, wealth of clinical data, huge numbers, it's an unwieldy heterogeneous population, just like you know from your take, multiple diagnoses, multiple pathways of care. It's a huge data resource, but you need to be patient. It's going to take time in order to get disease-specific data analysed in a meaningful way and across to you such that there are worthwhile take-home messages. And I think it's likely to complement specific studies such as ACP are setting up in a prospective study of bowel obstruction that's going to start, we hope, in the summer. So what I've not shown you is the hospital-specific funnel plot of outcome. That's confidential till the NELA report is published come the summer. Early July it'll be out and will be available on the website for you to look at. It will have individual hospital mortality stats, and it will look something like this along with figures there. This is again from the Saunders paper. One thing we just need to think about as a profession though is where we start thinking about care isn't that good and we really need to do something about it. The statistical measurement is the 3 standard deviation outlier, which is 99.8%. So to be in the bottom 3 SDs means you need to be in the bottom 0.1% of all hospitals, 1 in 1,000. And I just put it to you, if your relative was being taken to a hospital in the worst 1,000th hospital, you wouldn't be very happy. And some of the other work looking at this looks at bottom quintile, bottom quartile, bottom 10th, bottom decile, etc. And really it's about quality improvement, but we also need to have a conversation about what sort of level professionally we're happy with. So in summary, Mr. Chairman, the NELA audit shows considerable signs of engagement by the surgical community, improvement starting to be shown across a range of things, which I think reflects the huge input that many people have made. There's still considerable hospital or inter-hospital variation. What do we need to do? We need to know our own results. You can download your own unit's data and look at it and discuss it every month. You can use the suggestions in the NELA report for local change to services and use the figures to beat your medical director around the head to get resources. Develop an agreed hospital pathway for laparotomy, and as we'll hear in later talks, think about the elderly. Thanks very much.
Thanks, Iain. Excellent. There are 4 microphones available for people to ask questions if you have questions. So please come up to the microphones given the size of the auditorium. Just while people are making their way up, one quibble, the NELA entry data for responsible surgeon has, I think it's senior surgeon, something or other. But it doesn't say whether they are scrubbed, present, in the coffee room. And I think some people have had problems with that particular figure on the basis of they filled it in strictly, honestly, as in scrubbed for the whole operation, versus others have looked at it from the point of view who's around, who's available. Any way we can change that to improve accuracy of that data?
You can change, or you can request to change the data entry criteria. You need to do it by about July for the next year. It changes every December. So the group is always reviewing suggestions to change. I guess the thoughts there are that the first step was to have consultants involved, interested and present. How far you take that, I think, depends on the resources in your hospital, the expertise of other people, what the case is like and what impact it has on outcome. There's also a need to train tomorrow's surgeons, but certainly in the way our practice works, a trainee on their own probably wouldn't have enough competent pairs of hands to carry out a laparotomy or a complex laparotomy without the consultant at least being there to hold the retractor. And that probably impacts on that too. But how hospitals fill it in is probably going to depend on them. I'm not sure we'll be able to police it that much. But
a post-CCT fellow working with an ST5, with you around or in the coffee room would be?
Yeah, I think it's up to the individual hospital, but I think that's certainly one way to look at it. But that then introduces the whole thing of what do you call a post-CCT fellow?
Microphone 4, please.
Mike Lavelle-Jones, President, Royal College of Surgeons of Edinburgh. Fantastic data. Has there been any look to see if the outcome's different weekends compared to weekdays? Because that's such a topical issue at the moment.
Yes, we were just talking about this before we came in, and the first year's data didn't show anything conclusive. It showed that many of the processes, consultant presence, etc., particularly of surgeon, were identical through the weekend. I'll say it quietly, anaesthetic presence fell off more at the weekends. Outcome figures, my recollection of year 1 data is they were not significantly different.
Yeah.
Year 2, I don't think we've looked at, in all honesty, which, given the hot potato-ness of it, is maybe something we need to address between now and July.
Yeah, excellent. Thank you.
Microphone 2, please.
Nick Newton, I'm a senior surgical trainee. Do you think the NELA data is starting to push the case for acute care surgery / emergency surgery again, which seems to have tailed off in interest amongst the surgical cadre?
Has acute care surgery tailed off in interest? Discuss. I think it's probably going through a period of consolidation after a lot of change. I think one of the later speakers will put some of the angles on the other side, so it might be interesting to revisit that after Hugh Paterson's talk. I think, is NELA pushing the case for that? I think yes, it's one of the vehicles that's making us pay more attention to how we look after our urgent patients. And it's clear that they need a different model. In an MDT-driven elective practice, coping with emergency work, stuff within 24 hours, is a totally different model. And we could argue back and forth, is that better done by an acute care surgeon? Is it better done by a specialist who takes their turn doing acute care surgery? And all sorts of other things come into that. How many specialists have you got? Will they do it? Will their chief executive make them do it? What techniques are you trying to do differently? Laparoscopy is one that might leap out at you. So yes, it's a vehicle for change. Does it relate exactly to ACS? Not sure, because there's many other angles to acute care surgery. A good question.
Certainly our chief executive, I understand, Whitehall too, were very impressed with the quality of care during the recent strike, which had 4 consultants looking after the patients in our institution.
Yeah, I was the same. I was on call on the first strike day, and I wandered in on the Tuesday, and there was a bariatric patient bleeding. There was a gastric volvulus that was necrotic. There was somebody else going back, a trauma case or something, going back to theatre. And there was a load of new patients to see. So I was actually quite pleased it was the strike day, and there was a team of consultants who all took care of that, because I'm not quite sure how I'd have coped with all that on my own, but it's an interesting point.
Perhaps that's the future. Okay, thanks, Iain. Excellent. Next speaker, I'd like to invite Dr. Dhesi to address the topic of tomorrow's big issue, emergency general surgery in older patients. Dr. Dhesi, thanks.
Thank you very much. Tomorrow's big issue, probably this, but actually for this audience, probably emergency general surgery in older patients. But before we get on to talking about tomorrow's big issue, what we really need to recognise is today's big issue. And today's big issue is older people. And just as Iain has demonstrated from the data coming out from NELA, the majority of patients having emergency laparotomy are older. So around about 50% of our patients are aged over 70. And what we've also seen from the NELA data is that this is the group that is the highest risk group. So at the age of 70, having a 15% chance of mortality after emergency laparotomy, and in the over 80s, rising to 1 in 4 of our patients dying within those 30 days after the operation. What NELA yet hasn't told us is about why this group of patients dies, but of course, clinically, we know that they die because they have complications. And that's been shown very nicely in literature from elective GI surgery, showing that if a patient has any major complication after an operation, then it affects their 30-day mortality. But actually what's interesting within that is that if you have one of those complications at that time, it actually causes an excess of mortality even at 5 years post that surgical intervention. And what's actually quite interesting when you start to delve into this data is that our older surgical patients don't have that much more surgical complications in comparison to the younger population. So if you look at anastomotic leaks in elective colorectal surgery, they're much the same in the over 80s as they are in the under 80s. But what's very different is the rate of medical complications. So the cardiac, the respiratory, the renal, those kinds of problems that we see far more frequently in older patients. And those kinds of complications, when we start to look at the timing of those, we see that they tend to happen not within initially those 24 or 48 hours. It tends to be day 3 or so onwards, when patients are generally being managed back on general surgical wards. And we also, if you look at the timing of death, that tends to happen after day 7, again when patients are back on the surgical wards. And of course, that's not really surprising to any of us. We'd expect older people to do worse. And the reasons why we probably expect them to do worse is that we know that the predictors of adverse post-operative outcome fall into 3 main camps. So a reduction in physiological reserve, making a patient vulnerable, the presence of multimorbidity, so more than 2 coexisting conditions, or frailty. And so most of the anaesthetic and surgical literature which is coming out shows that it's really these 3 factors that put people into that higher risk group. And of course, aging is associated with all 3. So as people get older, they lose functional reserve, and particularly cardiorespiratory reserve. They are also more likely to be multimorbid. So if you take the average 70-year-old in the UK, they are likely to have more than 3 coexisting medical conditions. And of course, aging is associated with frailty too. So no, the kind of pathophysiological profile of older people makes it unsurprising that they do badly. But the other thing is that our models of care don't really respond to the needs of that particular population. So the national reports have been very good at highlighting gaps within clinical service. And what we've seen from those national reports is that 4 out of 5 high-risk older patients go back to general surgical wards. They are predominantly looked after by junior members of surgical teams. There's poor recognition of those medical complications and a reliance on the on-call medical registrar who changes every day of the week with slightly different opinions and multiple team involvement, so cardiac and respiratory and renal, coming in to see those individuals. So, of course, older people are our issue today because more than 20% of the UK population is aged over 65. But in 20 years' time, 30% of them are going to be over 65. And of course, with changes in societal attitudes, legislation outlawing age discrimination, and all of the advances that are being made in surgical and anaesthetic technique, we are going to continue to see more and more older people having elective, but also emergency surgery. So this is today's issue and increasingly tomorrow's issue. And this then poses us with specific challenges, and it poses those challenges to the whole of the NHS really, as to how do we ensure that we're delivering evidence-based care to this complex group of patients. Do we have the evidence? And if we have it, how do we translate it into routine care across all trusts? Does our workforce really understand the population? Are we all recognising that actually this is the mainstay of our work, older people? And is our workforce ready for that? Have they got adequate education and training? And how do we ensure that that does happen? And really for both of those points around developing an evidence-based clinical practice or developing the workforce, we need to make sure that our research agenda really matches our population. And this is the kind of research that isn't kind of as appropriate for the kinds of methodologies that we've all been very used to in the medical world of RCTs. Because these are complex patients with multiple issues going on, undergoing multiple complex interventions, and so actually splitting out patients into RCTs becomes very difficult. But despite all of that, I think, obviously we've been making lots of progress in this field, and I think we do have evidence to support certain steps in implementing care or higher quality care for this vulnerable group of patients. As Iain's mentioned already, I think one of the most important things is making sure that we are assessing risk in every patient who comes in onto a surgical take. But assessing risk is important kind of only if it's followed by a certain number of further steps. And those steps are first of all, modifying that risk. So if we do identify that a patient's at risk of acute kidney injury, we actually do something about it. If we know that they're at risk of delirium because of their underlying predisposing factors, that we employ prevention strategies to reduce the severity and the duration of that delirium. But then also using that information to make sure that the care is delivered in the right place. And normally when we think about that, we think about it informing whether a patient should go to level 2 or level 3 care. But actually there's more kind of detail that we ought to be thinking about. If we have a patient who's at high risk of falls, they should be managed on a low bed near the nurses' station. Or a patient who's particularly prone to becoming very agitated, potentially a side room with other support may be appropriate. So it's even thinking at that kind of level. And the other thing is that, of course, once we've assessed risk, we know that we can't get rid of it altogether. But what we can do is manage that risk better. So modify it, but then predict the likely complications so that our staff on the wards know what to look out for in a proactive way and to manage it in a standardized way. So if a patient's at high risk of getting uncontrolled AF because actually we know that they have paroxysmal atrial fibrillation, then ensure that they have their potassium above 4 and their magnesium sorted, and the juniors know what drug to use when. And a lot of this is very predictable. And obviously, underlying all of that, we need to be documenting those outcomes in a meaningful way, meaningful for us as clinicians, but meaningful from a patient's point of view as well. And then the other thing that we're gathering more and more evidence for is the need for this shared decision-making process between us as healthcare professionals, but more importantly, together with the patient and their carers to decide what's in the best interest for that particular individual at that stage in their surgical pathway. So, of course, this needs a particular team that's working in the right place at the right time and following the patient from pre-operatively, intra and post-operatively, delivering all of those aspects of care. And I think what's becoming more and more apparent as we respond to the changing demographics of our population is that this can't remain to be a specialty provided service. It needs to become a patient-centred service with the right specialists coming in at the right time. And certainly our surgical trainees are recognising that this isn't where their strengths lie, that they don't have adequate education and training in how to assess and manage these complex older patients, and require support from that wider team. And that's echoed from all of these national reports which are coming out, kind of saying, actually, we need to broaden out the healthcare professionals who are involved throughout the pathway. But unfortunately, as NELA has shown, kind of not very many emergency surgical patients actually are being seen by geriatricians across the country. At the moment, probably around about 10% post-operatively, with 20% of hospitals not having any elderly medicine support on site. And those results really echo some of the findings of a survey done a couple of years ago, which also showed that really there are only 3 hospitals in the country providing a perioperative medicine service for older people by geriatricians, and 26 out of 130 trusts providing any level of post-operative support. So no, we recognise that us geriatricians aren't doing what we probably ought to be doing for this group of patients. And that's despite all of the guidelines that we're also being thrown at us, saying that we need to get more involved within this patient group. So there's guidance out there telling us how to do it, when we should do it, what we should do, but it's not being translated into routine care. And we'll come back to that later on. What we have started to do, though, is that we have started with a number of centres around the country starting this kind of work. And kind of the work that we've been doing at Guy's and St Thomas's started about 12 years ago, where initially we were focusing at the elective patient group, and that's then been adapted to focus on the emergency group. So this is the schematic for what we do for the elective group. Patients who have been labelled as being medically unfit, or patients who are frail, functionally dependent, or have problems around decision-making are referred into a geriatrician-led preoperative assessment service, which is a multidisciplinary team. And the focus of that assessment is not only that risk assessment, but optimization across that range of pathophysiology, and then followed by decision-making with liaising with the patient, the surgical team, the anaesthetic team. But crucially, the important bit here is that there's follow-through throughout the pathway. So the team continues to see the patient when they come in onto the surgical ward and are involved in the medical management, the rehabilitation, and the discharge planning. So whilst kind of that been fairly well established within elective surgery, over more recent years we've started to get involved in the elective group, and that's required quite a bit of adaptation. And it's required adaptation of a process that we use, which is called comprehensive geriatric assessment. So this is a methodology which we use throughout geriatric medicine in a variety of different settings, but has a very good evidence base in terms of improving outcomes for patients. And there's good evidence base in medical settings, in the community, and now increasingly within the surgical setting too. And so using that methodology, we've tried to adapt that into the emergency general surgical population as well. And of course, a number of steps need to happen for that. We need to make sure that we know about every patient coming in. So that's meant that we've had to make sure that every patient is electronically tagged as being an emergency general surgical patient. So they go off to all kinds of wards around the hospital. But then employing a clerking pro forma, which is used for all of those patients, but includes assessment across those risk factors. So looking at physiological status, the multimorbidity, the frailty, but having screening tools that our surgical juniors can do as very quick assessments there and then on the clerking pro forma, followed by more in-depth assessments that the team does once they've identified the patient as requiring input from us. And really then that follows into this kind of pathway where we're involved throughout the admission from the moment that the patient's kind of known to us, involved in the diagnosis, involved in risk assessment, and the risk assessment kind of using things like Preoperative, which are fantastic for looking at mortality, but also starting to look at some of the patient-reported outcome measures and the risk of longer length of stay, so the process-related outcomes. Using that for shared decision-making, using that for informing management decisions, which tend to happen collaboratively with the team, together with the surgeons and the anaesthetists. And I think the important thing to remember from this really is that most of our patients don't actually go on to have surgery. So 40% of a take goes on to have surgery, and the remainder may have a procedure or medical treatment. And even with those surgical interventions, some of that's done pretty quickly, and others happen much later along the stay for a variety of different reasons. And so POPs is involved in these different aspects around optimization, communication, both with the patient, but then also with the teams. But importantly, in hands-on care on the ward. So actually being there on the ward rounds, picking up patients every day, medical management, goal setting, discharge planning, the case conferences with those difficult longer stay patients. And the exciting thing is that these kinds of programs are being replicated across the country, and certainly in Salford, they've been making great strides with this kind of work, and really using very clear process mapping with a shared goal of reducing length of stay by a fixed period of time and splitting things out into primary and secondary drivers so that we can really get the whole team engaged with that. Ensuring clear documentation within the surgical notes, which has resulted in some really interesting data which is being submitted for publication, so it's not quite there yet, but these are the kinds of findings with reductions in length of stay, readmissions, improved coding, so that we're really starting to understand the profile of the patients better. Lots of added benefits in terms of education and training for healthcare professionals, but also for patients and carers as well. And of course, so we could go back to saying that, there are lots of different issues going on at the moment that we all need to be engaged in thinking about. But in terms of emergency general surgery, I think we could summarize it into 3 different areas. That we need to think about adapting our services to be patient-centered services rather than being specialty-centered services. This is going to require whole system reorganization of the way that we manage these patients. And of course, that's going to require funding, and we need to work jointly to influence CCGs in funding those types of services. We need to have a rethink about how we're educating tomorrow's doctors, because they are predominantly going to be looking after older patients, and everybody needs to understand the basics of looking after complex, frail, older patients. And we need to move forward with the research agenda to really make it real-world research, which NELA is a prime example of, using real-time data to influence quality improvement methodology. And there are lots of resources, and I think it's about being aware of those and sharing them across different specialties so that we are all working towards a common goal. Thank you.
Questions are invited from the floor. Just while you get into the microphones. We had a fellow working with us for a year in Leeds, a geriatrician who was excellent. She made a massive difference in terms of preoperative assessment of the patients, and probably in particular identifying what needed to be done to have that patient treated and streeted, in other words, get them out once they've been sorted out. She was excellent. She was one person on a fellowship salary.
Yep.
All that looks very impressive, but it does seem awfully heavy in terms of manpower and probably time as well. The last thing we as surgeons want is yet another MDT setup. Can we do it with just one geriatrician attached to, say, a colorectal service or a upper GI service?
Yeah. So in our colorectal service, it's actually predominantly run by an advanced nurse practitioner who has examination skills, prescribing skills, ECG skills, and functions as a senior registrar on the ward. So although he runs that very much with consultant support, it doesn't need to be hands-on geriatrician care for every individual patient. But of course, there needs to be that clinical supervision and taking accountability and responsibility for those difficult situations. And certainly in Salford, that at the moment the service is being run with 4 PAs of consultant time, with other members of the team then supporting it and training up the surgical staff on the ward as well to be able to deliver some of those aspects of care.
Most frustrating thing for us is not understanding the social package that are needed. We haven't got the time to organise with that. That should be a geriatrician's responsibility.
So I think the one thing that we want to be very clear about is that geriatricians aren't social workers. So, you know, there is a separate discipline of social workers. But what we are very good at is knowing when people still have rehab potential, when they don't, and what services they require, and what is available in the areas in which we work. And we also know how to navigate that system around kind of social services, which of course, you know, with all of the changes that are happening, we're going to run into real difficulties, and certainly kind of in our local boroughs where there's been 30% cuts in social services, you know, that's the predominant issue for social service provision at the moment.
Sorry, I wasn't trying to be rude about geriatricians.
I know, but I have to get a laugh.
Or indeed social workers. Microphone 3, please.
Vas from Paterson from Southampton. Our orthopedic colleagues in many places have taken the route of employing their own geriatricians to look after the patients. So for general surgery, do you think there's a place for geriatricians with a specialist interest in general surgery, or you think the existing services can support surgery?
So I think the existing services at the moment are very stretched in geriatric medicine. So we have around about 40% consultant posts unfilled across the country. So this is a real issue for us as to how do we address this problem where we can recognise there's an issue, we think we can help with it, but we don't have the manpower. So I think there's 2 kind of components to that. Yes, I think there has to be geriatrician input, but the geriatrician may then be supported by clinical nurse specialists or advanced nurse practitioners actually delivering some of that hands-on care. What's worked very well for hip fracture has been the linking of the National Hip Fracture Database with the best practice tariff. And the best practice tariff then supporting the employment of geriatricians, so that's how the funding then ends up coming up. And I think that may be something that we need to think about with NELA in the future as to how do we package the cost involved in managing a patient throughout that pathway in a way that we can then convince CCGs that they need to be buying the package. So 2 separate issues. One is the workforce availability, and then the other thing is actually funding services where there is a workforce available.
Do you think that geriatricians would be attracted to such jobs?
Yeah. So we run an annual conference for this, and we're in our 5th year. It's been sold out every year. Lots of trainees applying for posts with us. So there's a real interest in delivering this kind of care from the juniors coming through.
That's encouraging. Microphone 4, please.
Hi, John Saunders, Nottingham. Thank you much for your talk. I really enjoyed it. I understand from our surgical colleagues at Guy's and Thomas's that many of your surgical patients are spread around many wards around the hospital, such that they sometimes even describe their ward rounds as a safari ward round, just like many of us in many trusts. I wonder if you could comment on how this affects the ongoing care of the patients, both with the junior doctors being different on the different wards, and also the skill mix of the nursing staff on these different wards and how that affects continuity of care with many of these particularly subtle comorbidity-related issues.
So yes, I think at GSTT we have the same problems as anywhere else in that people are scattered across the hospital, although we do tend to try to have people on the same floor with 3 wards where predominantly our GI patients are. I think the nice thing at GSTT is that there's been a lot of work done at upskilling all of the nursing staff around geriatric medicine issues, and particularly around things like delirium and dementia and functional assessment and those kinds of things. So it is important to have buy-in from the chief nurse at ensuring that the whole of the workforce does become upskilled. In terms of the juniors, we've actually we had 10 juniors taken away from general surgery last year. And so what we've actually done is moved them into perioperative medicine with us. And so they work on a modular system with us where they do 2 months on a surgical ward, but dealing with these kinds of issues, the geriatric and the medical issues, and then a month doing preoperative assessment and community-based work so they can understand the whole of the surgical pathway. And certainly having them now based on the surgical wards means that we're able to deliver some of these aspects of care much better than we were able to previously, but obviously requiring lots of supervision.
Final question, microphone 4, please.
Yeah, Peter McCulloch from Oxford. As you'll be aware, there's a kind of ongoing debate in this society and elsewhere about the emergence of a specialty of emergency general surgery. And one of the points at issue is, what are they going to be specialists in? Surely one of the answers is pre-operative and post-operative care of elderly patients. Therefore, what do you think about a model where instead of employing a new cohort of geriatricians, the geriatricians train the surgeons?
Yeah, no, we're very keen on that, and we're very keen on trying to upskill our surgical colleagues in aspects of this type of care. But it's unusual to find surgeons who do want to be delivering all of that on the wards. But it'd be great if we've got an emerging cohort who want to be upskilled in that, and we'd be very up for helping with that kind of training. And I think that's exactly where the Academy of Royal Colleges needs to be focusing, is on some cross-college training as opposed to being specialty focused.
Okay, thank you very much.
Thank you.
Thank you for inviting me to talk to you today about emergency surgical ambulatory care. And more importantly, I would like to share with you what has worked for us as a unit and what hasn't. So the NHS at the moment is experiencing unprecedented demand at the front door. In our own hospital, we've experienced a 28% increase in our non-elective emergency and medical workload within the last year, and that's not unusual. This graph shows our ED ambulance conveyances over the last 5 years. The grey shows the spread of ambulance activity, and you can see over the last 2 financial years, the blue being the most up-to-date, that we've experienced quite an increase in our ambulance activity, particularly over the last winter. And the importance about ambulance conveyancing is that these are patients with a high acuity and often with multiple comorbidities, and as a hospital we are struggling to cope with these patients. So the purpose of my talk today is to move away from about what we've heard so far about the really sick patients who definitely need a bed for a laparotomy, or the much older patient, but to talk about the patients at the other end of the spectrum, those patients who are actually relatively young and fit and could be managed without putting them in a hospital bed. Ambulatory care for these patients is a really very quick win, and it is very rewarding. There are some basic rules that patients should be told that assessment is a default, not admission, and managing patient expectations and GP expectations accordingly is paramount. We should stop thinking about beds as capacity. We should think of personnel as capacity and wherever possible manage patients without a bed. And we should shift as much as we can into the outpatient setting with allied and ancillary services for our own sanity so we can manage these patients in a controlled fashion. So for those of you who are unfamiliar as to how ESAC works, it was in our unit it's based loosely on the Derby model that was set up by Jill Tierney and colleagues. And that's for a proportion of patients who can wait until the next clinic or ambulatory care activity. The first point of contact is in fact the consultant. Locally, we have been very lucky with resource, and we have dedicated diagnostics, which I'll explain to you later, but from ultrasound scan, CT and MR. We then, for ambulatory care patients, have our own dedicated day case list in the afternoon, which is running as well as our 24/7 NC pod theatre. And we've also developed the concept of a virtual ward for patients who would continue to keep an eye on and review, and that's being managed by emergency surgical nurse practitioners. So we put together a business case in 2013 that was approved for just under £500,000. With that, we were able to fund a trolley-based assessment area with 4 trolleys. Those trolleys are used in the morning to see patients, but also to take patients to theatre in the afternoon. We also have 2 treatment rooms. We now have 3 consultants supporting the service, 2 emergency surgical nurse practitioners, a dedicated ultrasonographer every morning, as well as an ultrasound machine, and a dedicated CT and MR slot for the service. We've also trained up a scrub practitioner to assist with the lists and coordinate the lists in the afternoon. And as I say, those lists are running as well as the 24/7 NC pod list in main theatres and a virtual ward. So what have our outcomes been so far? We've seen just over 4,500 patients. Overall, we see between 25 and 28% of the take, and we only admit 8% of patients that we see. Conservative estimates is amongst that group of patients, we save 160 bed stays per month. And because we have extra theatre capacity within the system, our preoperative length of stay for those patients waiting on NC pod has also come down, and we have saved another estimated 30 bed stays. Patients really do like the service, as do the general practitioners. And of the 4,500 patients we've managed on a fully ambulant basis, we report no adverse incidents. So I put these slides together on Wednesday, the 4th of May, and I thought it would be a really good illustration to just show you the activity that morning. This wasn't a particularly busy morning, and this isn't the glamorous stuff, is the honest answer. But the first patient we saw had a straightforward back abscess. The emergency surgical nurse practitioners are now trained up to do that and did that in our treatment room for me. Second patient came in with right iliac fossa pain. She had bloods, a transvaginal scan and a urine dip. Scan showed she had an ovarian cyst accident and she was referred to gynecologists. Second patient presented with biliary colic and had the diagnosis confirmed and went home later on that day once she was comfortable, having been put on our elective waiting list. The fourth patient is more contentious, but by midday the diagnosis of a contained diverticular perforation had been made. She was home mid-afternoon with a PICC line in, having a single dose daily antibiotics and being put in our virtual ward for a daily review, and she's about the 30th patient we've managed on this pathway now. The fifth patient had a diagnosis of acute cholecystitis and was taken to theatre that afternoon and left home later on that evening without their gallbladder. The sixth had non-specific abdominal pain and was discharged home immediately. And the seventh had a diagnosis of appendicitis and again had a lap appendix that afternoon and was discharged home the same day. So that's a general feel of the sort of activity coming through ambulatory care. So what's worked for us? We do not have protocols. We started to write protocols and found them very restrictive. In the end, we went out to GPs. We told them the sort of patients that we would be willing to accept. We wrote information leaflets for them, and we also produced an information leaflet for patients. It was actually quite a difficult leaflet to write because we were having to cover the base that they might only be seeing us for about half an hour and would go home, or they might be admitted, or they might even have an operation, and some starving guidelines accordingly. We also educated our inpatient teams and increasingly see accelerated discharges in ambulatory care. So those patients who've had a prolonged, lengthy stay in hospital on the traditional pathway that may just need their bloods checked within 24, 48 hours, a drain removing, and so on. We do, however, now see more or less anything that can safely wait till the next morning if they are an adult. The other thing that's been a great success is our emergency surgical nurse practitioners. They are now trained to incise and drain all our non-perineal abscesses under local anaesthetic. They run nurse-led clinics in the afternoon, particularly for the accelerated discharges, under the umbrella of the consultant. They perform the telephone contact for all those patients being managed in the virtual ward. and have the ability to administer IV antibiotics both in the community and place PICC lines, remove drains and vac changes. And the thing they are really very good at for us is collecting data and driving quality improvement projects. The other thing I think we've got right is the dedicated radiology in theatres. Moving these patients swiftly through the system is about making sure that the waits between steps are really kept to a minimum. 62% have an ultrasound scan, and that's Tracy, our ultrasonographer. She can scan 16 to 18 patients a day for us instantaneously and provide an immediate report. 12% will have same-day surgery on our ESAC lists. 15% will go home and wait surgery either to have it that day or the next day. And on average, we perform 450 cases per year on our ESAC list. And again, it's not necessarily the glamorous stuff, it's the EUAs, lap choles, lap appendixes, defunctioning stomas, but I think you'll all recognise those are the sort of caseload of patients that can wait some days in a hospital bed waiting to be done on NC-pod. As the service has evolved, it's become very clear that our acute biliary patients do particularly well in ambulatory care. And we've recently been funded to do with a quality improvement project with a health foundation to support this group of patients. We historically had not been serving them very well. 28% of our readmissions locally had been biliary. And patients put on, following gallstone pancreatitis, were being put on our elective waiting list, and 9% were coming back in with recurrent episodes of pancreatitis while they waited. These patients are now sent home. The ESAC team are notified. They're put in our virtual ward and are brought back in and performed on our day case ESAC lists. And we really have been able to drive down their length of stay while they wait for these operations. And we now also have a formal pathway for our acute cholecystitis. They are also managed on our ESAC list if at all possible, even if they need to stay as inpatients and wait for their surgery. And our activity really has increased. So I think as surgeons we don't like talking about the money, but I'm going to talk about the money. For those in the audience that don't know, but emergency tariffs were capped in 2008. So if, for instance, your hospital had done 50 acute cholecystectomies in 2008, you will be paid for up to 50 acute cholecystectomies this year, and thereafter your tariff will be reduced to 30%. And with new NICE guidelines suggesting that all acute cholecystitis should be done on their index event, it means that for the majority of hospitals, they will be working at a loss. ESAC was commissioned by 3 local CCGs. We see patients at a dedicated tariff of £765, and that offers them quite a lot of savings compared to £1,600 for an admission. If a patient was admitted with acute cholecystitis, at the beginning of the year, your hospital would be earning £3,000, but by the end of the year, they'd only be earning £1,000 per surgery performed. But if they're seen in ESAC, we have agreed with the commissioners they will stay on an elective pathway, and therefore our tariff won't be capped. I'm often told that ambulatory care must be removing training. However, the overall numbers being admitted via the take are unchanged. As I say, our denominators are actually going up faster, even though we're working differently. So the numbers we're seeing on the take are fairly unchanged, but are of much higher acuity. As we've heard before, F1s are being stripped out from hospitals, but we've been able to preserve our F1s because ESAC is viewed as a community-facing week. And we have to accept that most of our F1s actually want to be general practitioners and not surgeons, and therefore this is excellent experience for them. The ESAC lists are a really good training opportunity for our core trainees as they want to step up to ST3, and the complex biliary cases are fought over by our advanced trainees, and the cases have been used to train nurse practitioners and scrub practitioners. Things we've struggled with are managing both staff and patient expectations. The ESAC list is finalised at 11:30 for a 1:30 start, and that's been a real shock to our day case staff who are normally used to knowing what their lists are many days, if not weeks in advance. Similarly, this is our list of patients who had been waiting for operations at home, They are contacted the day before, they're given starving instructions, and then we confirm in the morning whether we have an ability to do them. And sometimes it can take 2 to 3 days before we can bring those patients in. We have not yet had a complaint because they do not have a wasted trip to hospital, and we have to very carefully manage their expectations. Clearly, if they become unwell, they're given priority. Sadly, we do not work in a protected area. These are our 4 trolleys we work through. When the hospital goes into black escalation, the trolleys are removed and they are replaced by beds. And as you can see, as the percentage of days that we're unable to work with at full capacity in green go up, we're able to see less patients, our bed savings reduce, and actually we go into a vicious circle. And I argue that actually this is the one time when we should be absolutely protecting ambulatory care. I don't think rectal bleeds are well served in ambulatory care. I think they either necessitate admission or they don't. I think seeing them back in ambulatory care is an unnecessary trip for them. And we now, if paper triage them, the consultant will paper triage them to follow up if they meet these criteria. The complexities of the tariff are a talk in themselves, but we can't be seen to be double charging and everything needs to be above board. And if a patient has already been seen in hospital within the last 28 days for the same problem, we obviously do not charge our commissioners. But making sure that we bill accordingly and fairly has necessitated a very complex outcome form. So, Mr. Chairman, ladies and gentlemen, if you're thinking of setting up emergency surgical ambulatory care, I think dedicated diagnostics are crucial. The service must be delivered by a senior. As soon as a registrar has in the past gone to clinic, our admission rate will go up. Get trainees involved. It really is great training, and establish an appropriate tariff in a protected area. Use a virtual ward concept. We safety net all our patients. They can have access to us 24 hours a day. Dedicated theatre list is a must, and I thank my supportive colleagues in hospital and management for allowing the service to develop. Thank you very much.
Excellent, Sarah. Very enjoyable and very informative. I'm very much going to set up one of these ESAC teams. I'll tell you why. Your comment about keeping the FY1s by having an ESAC service.
Yes.
Who did you speak to keep the FY1s? So we lost about 10, all to psychiatry, of all things.
So TPD, in fact, she took the concept of ESAC to the national TPD meeting following the feedback, and many other trusts are interested in a similar idea. So F1s were being removed from the acute hospital setting to go into community-facing and psychiatric positions, but if we can illustrate community-facing teaching, then we were allowed to keep our numbers.
It was the foundation TPD you went to? Okay. What about the deanery? Because the deanery is the one that takes them away, ultimately.
Yes, so she had that clearance from the deanery.
Okay. And define ESAC then. What sort of definition do we have to use to sell this to the deanery?
You have to show that it's not subspecialist, and we spent a year collecting feedback from our trainees, very positive feedback, and she took it to the deanery.
Feedback being the GMC questionnaire, presumably? Okay.
Yes.
Thank you. Microphone 4, please.
Alex Navarro from Nottingham. Sarah, congratulations on delivering such a superb service. We're about 3/4 of the way doing what you're doing in Nottingham, and we've also got our close neighbours in Derby, who you mentioned at the beginning of your talk. Locally presented data last week suggested that 23% of their consultant shifts in their ESAC version are unstaffed. Why have you succeeded and sustained this where others are having problems? And second question, you seem to have very compliant commissioners. We don't have those. Have you got any tips for how we present this to them?
The first thing to say is that we now have 3 consultants that staff ESAC, but we have been absolutely clear on their job plans that they will have an elective subspecialty interest, and I think that's the only way to really recruit effectively. To answer your second question is that when we piloted ESAC, we did so on an at-risk basis that we could charge the full non-elective admission for every ESAC patient seen, so the full £1,600. So we could then come to a reasonable tariff. And for every patient we saw for the first 6 months, we calculated the amount of clinician input, bloods, scans, and so on, so we could come to a fair tariff. And the other point is a high tariff like that does disincentivize abuse of the system.
Thank you.
One last question. You mentioned about incision and drainage of abscesses done by nurse practitioners in the treatment room.
Yeah.
Under local anaesthetic?
Local anaesthetic and gas and air, yeah.
Oh, gas and air, okay. Not perianal abscesses?
No, non-perineal abscesses or patients with comorbidity or large abscesses or anticoagulants will be done in theatre.
Not tempted to do the perianal abscesses?
Not yet, no.
Okay. Okay, lovely. Thank you very much. The final speaker is Hugh Paterson, who's going to address the topic of emergency versus specialist care. Is it the specialist or the system?
Okay, thank you very much. So, specialist or system? So we'll take those in turn, and I've treated this as a kind of overview of the literature rather than giving the partisan Edinburgh view. So, everyone's a specialist nowadays, aren't they? Some are more specialist than others. But if you put specialisation or specialist and emergency surgery outcome into PubMed, you don't actually get an awful lot of data back. A lot of it is on acute orthopaedics. And what there is in general surgery is predominantly colorectal. So we'll look to the colorectal literature about the impact of specialisation first. So these are early colorectal, predominantly cancer audits that were published in the UK. And they showed that there certainly was intersurgeon variability in outcome measures. Keep a note of the Lothian Borders audit in '95 there. I'll come back to that later on. And that was supported by Bill Heald's data showing that an individual surgeon could make quite a difference to colorectal outcomes. And then a second tranche of audits in the early 2000s, one in Wessex and another one in the west of Scotland, again suggested that specialisation was an important factor, more important than caseload, although perhaps not supported by a similar type of audit from the north of England. Note that the overall emergency mortality in these colorectal cohorts was of the order of 20% or so. So if you look for more specific evidence of the impact of specialisation, we published some data from Edinburgh, which was taking cases in acute diverticulitis before and after the formation of the subspecialist emergency colorectal unit in 2002, and showed that there was an improvement in mortality, a reduction in the rate of stoma formation, with an improvement in primary anastomosis rate. And David Bartolo, who was one of the key instigators of setting up a specialist emergency colorectal service in Edinburgh, has subsequently left and gone to Fremantle in Australia, and he has recently published data which is really quite similar and shows the impact of colorectal surgeon specialists versus general surgeons in emergency diverticular outcomes. Again, lower stoma rates, higher primary anastomosis rate, higher consultant presence. And that data has sort of been replicated by Sebastian Biondo, who's a colorectal surgeon in Barcelona. And again, colorectal surgeon outcomes were better for emergency surgery than general surgeons. The trouble with all of these publications is that there's a little bit of a whiff of case selection about the two groups, which is difficult to overlook. So what about a Cochrane analysis, systematic review? And again, for specialisation in colorectal, there is evidence of improved survival from cancer and operative mortality, but there's also some evidence for high-volume surgeons. And essentially, that's about it. So what about the system? So I'm going to just run through a number of publications which follow a kind of similar methodology, and you'll probably be familiar with quite a few of them because they follow a similar structure. But they're based on evaluation of administrative data sets, for which obviously there are pros and cons. A lot of the data comes from the States, and there's various data sets, NSQIP, National Inpatient Sample, VA, etc. And then there's UK data from HES statistics. And I'm not a methodologist, but they all contain very large tables that look a bit like this, with odds ratios for many covariates. But the essence of them is that they have taken a spectrum of mortality and compared the best with the worst to look at what are important factors. And whether that's done by a funnel plot or by dividing the data into quintiles or terciles, the principle is more or less the same. So what system factors are important? Well, we'll take hospital volume first. And Omar Fayaz has published a lot of data from HES on some of these outcomes. This is data from about 40,000 emergency colorectal resections, overall mortality 15%, and they found no relationship of volume to outcome. Okay, so here's a more diverse general surgical population, much bigger data set this time, pretty contemporary data, still quite a range in 30-day mortality. But looking at the, if you like, the structural aspects of care, the important predictors of reduced mortality were ITU provision and essentially radiology provision, or certainly radiology use. So the latest publication on this sort of data published in the BJA this year, again a kind of mixed bag of general surgical admissions, 300,000 patients, very contemporary data. Lower mortality because a lot of those conditions dilute the high mortality from colorectal resections. And again, there are sort of structural suggestions that higher levels of medical care, more operating theatres, more critical care beds are associated with better outcomes. And once again, the weekend admission question raises its head there. And if you look at outcomes from other specialties, so ruptured aortic aneurysm, the same sort of themes emerge. So there are structural differences which seem to be associated with better outcomes. ITU provision, critical care, medical staffing, nurse to patient ratio, and so on. So maybe we just need more of all of those things, more beds, more operating theatres, more CT scanners. So this is an interesting paper that was published a few years ago looking at colorectal cancer outcomes in Denmark. And if you look really just at the colonic cancer emergency operations, you'll see that mortality was 22% across the country, but there was a huge variation in mortality between hospitals. And when they factored in the covariate analysis, for which there were a lot of covariates, it's a very detailed study, they found that when they went from the null model to the full model, the difference actually became even more stark. So there was something additional to patient factors and measurable hospital factors going on. Which leads us on to this data, which was published in the New England Journal of Medicine from the United States, and Gaffieri, Birkmeyer and Dimmick, again, are the kind of key names in this area. And they looked at quintiles of mortality across general surgery and vascular patients and looked at the complication rate and found that actually that the complications in these different mortality hospitals were broadly the same. Yet within the same hospital, with the same clinicians, the same patients, the gradient in mortality was associated with death after major complications. So it was what happened after the complication that was key. And that is now a very well-worn metric, which is known as failure to rescue, and you'll all be quite familiar with it. And in the US, that is now endorsed as a quality measure for surgical care by the National Quality Forum. And it turns out that this is replicated in studies of lots of different patient cohorts. So this is data from the state of Michigan, in emergency surgery in older patients. Again, the complication rates in the terciles of mortality are similar, but it's the failure to rescue that seems to make the difference in mortality. A bit closer to home, very similar picture from a Dutch national audit in colorectal cancer surgery. You can see that the failure to rescue gradient is really quite marked. between quintiles of mortality. Clearly, those are slightly different healthcare systems to ours, but does the same apply in the UK? Well, it does seem to apply, yes. So that although reoperation rates in these colorectal resections were overall the same, the failure to rescue is associated with the difference in mortality. So one more of these papers quickly. So this is the latest paper from Dimmick et al. Huge data set, and it's trying to tease out what are the important factors in this failure to rescue metric. And you can see there that themes are recurring. It's to do with hospital bed size. We would not really recognise a hospital occupancy of under 50%. At least I certainly wouldn't. And that's obviously a very different healthcare system. Nevertheless, they drilled down a little bit to look in more detail at to what extent these measurable factors actually explain the variation. And they found that actually the patient and hospital characteristics explained relatively little of the variation across these various procedures, and that most of it, in many cases, was due to other factors. So what are the other factors? I'll pass on that one. So first of all, it's the proviso of this sort of data is always that association does not imply causation. And therefore, having done with the science part, I'm now going to resort to anecdote. So this is the paper that I mentioned before, which was the 1995 Lothian Large Bowel Cancer Project. And it's very interesting reading it now for two reasons. The first is that the consultant participation in emergency colectomies was starkly different to their participation in elective surgery. And the second is that some of the outcomes were really not very good. And the colorectal surgeons in the audience can contemplate the impact of that plot of patients who underwent anastomosis versus those that leaked. Imagine taking that to your revalidation. And David Carter's discussion is really pretty forceful. And I think a lot of people would recognise this account even today. But the point is that that changed in Edinburgh, and I suspect that was quite a political paper in order to do that. And this is data from the UK Emergency Laparotomy Network data that Iain Anderson referred to earlier. And I'm going to out the Lothian Colorectal Unit because we are the BF. And the important thing is that in 15 years or so, there was a huge change such that the proportion of consultant involvement in theatre was nearly 100%. Very high anaesthetic involvement, and then particularly very high disposal to level 2, level 3 care. And once again, association is not, does not imply causation, but BF is the Lothian Colorectal Unit, which is the outlier there. So, is it system or specialist? Well, both of those are important, but the process of care is the other factors that is inherent in all of this, which is much more difficult to measure, but I think that's what hopefully the NELA audit process will begin to tease out. Thank you very much.
What's a specialist colorectal surgeon? A lot of the slides you showed at the start talked about specialist colorectal versus general. Technically, we're all general surgeons, as defined by, we have an SAC in general surgery, not in colorectal or in upper GI. So how do you tease out from that who are actually specialist colorectal, and what do you define as a specialist colorectal surgeon, taking this forward from 2016 onwards?
Well, it is very difficult to tease apart the specialist part from the systemic factors. So clearly in Edinburgh we've got many of the desirable criteria that Iain Anderson referred to in terms of the process of care. And the two are firmly enmeshed, and it's very difficult to dissociate the two. I suppose you could stand back and say if you do more of one thing, then you probably get better at it, and you probably make better decisions, and the more of these things that you see, the more you refine your decision-making process. So I'm not sure I can necessarily answer that very specifically, and it depends on the region you work in, I think. But intuitively, it seems that to make sense that if you do one thing, and we just do colorectal surgery, we do colorectal emergencies, which means that all of the emergencies in the region come to the Lothian colorectal unit, and that happens at GP, at sort of bed triage level. And we do a few hernias and appendixes and so on.
In Lothian, then, given that you are the outlier in a good sense, what are the key factors to get you to that position, would you say? The 3 factors if you were setting up a service that you would push to get other units to that level of expertise?
I think I benefit from having excellent support from ITU, from anaesthetic colleagues. We have a CPOD theatre that we can access immediately. We're dealing with recognisable pathology, which that we deal with day in, day out, and have excellent support from colleagues, all of whom I would say are committed to having very good emergency surgery outcomes. That is the priority for the unit.
And presumably they are dedicated to the acute when they're on acute, not doing any of the work at all. No scope list, no elective work, no clinics.
Yeah, that's right.
Okay. Okay, thanks very much. Thanks to all the speakers. Thanks for the questions, and we're finished on time. Enjoy your coffee.